Loop diuretics are substances that can selectively inhibit sodium and chloride reabsorption. Their site of action is ascending limb of the loop of Henle, and it's the most efficient diuretics on the market. To loop diuretics belong Bumetanide, Ethacrynic Acid, Furosemide, and Torsemide. Loop diuretics inhibit sodium-potassium chloride transporter, which is located in the ascending limb. By blockage of this transporter, they decrease the reabsorption of sodium, chloride, and potassium. But loop diuretics also have indirect effect. Loop diuretics, through decrease in potassium absorption, cause decrease in lumen-positive potential, which in turn cause increase in magnesium and calcium excretion. And to explain their mechanism of action, first of all, we have to recall physiology of ascending limb of the loop of Henle. Fluid that incomes to the ascending limb has a lot of sodium molecules. And recall that because sodium is osmotically active, sodium attracts water. So water molecules are always accompany sodium molecules. In addition to this, fluid also has a lot of potassium and chloride molecules. In the ascending limb located sodium-potassium chloride cotransporter. The function of this transporter is to provide reabsorption of sodium, potassium, and chloride. So this pump transports sodium molecules into the cell, and as we know, water molecules moves together with sodium. Also, this pump transports chloride molecules into the cell, and once chloride molecules appear inside the cell, they begin to leak out of the cell through the chloride channels into the blood, and by this, ascending limb provides the income of chloride molecules into the blood. In addition to this pump transports potassium molecules into the cell, and once potassium molecules appear inside the cell, some amount of potassium molecules begin to leak out of the cell through the potassium channels, and by this ascending limb provides the income of potassium into the blood. But ascending limb do not have sodium channels, so to provide the income of sodium into the blood, ascending limb has sodium-potassium transporter. Basically, this pump takes some amount of potassium molecules from the blood and transports these potassium molecules into the cell. And simultaneously, this pump transports sodium molecules into the blood. And because water molecules moves together with sodium, by this pump, ascending limb provides also reabsorption of water molecules. In addition to these three ions, fluid that incomes to the ascending limb has some amount of calcium and magnesium, but we cannot reabsorb them directly. In order to reabsorb calcium and magnesium, ascending limb has to create lumen-positive potential. And lumen-positive potential is created by the movement of potassium molecules out of the cell back into the lumen. This movement of potassium into the lumen creates a lumen-positive potential that basically stimulates reabsorption of calcium and magnesium into the blood. So by this, ascending limb provides the reabsorption of calcium and magnesium molecules. Let's suppose that during reabsorption in ascending limb, 5 sodium and water molecules were reabsorbed into the blood. So after the initial reabsorption, there are just 2 sodium and 2 water molecules left. In the distal regions, we have sodium-hydrogen transporter. This transporter provides reabsorption of sodium in exchange for excretion of hydrogen, and hydrogen for this transportation we take from the blood. By this hydrogen transportation, urine becomes more acidic. In the end, after the reabsorption, there is just 1 water molecule left, and this water molecule will be excreted into the urine. Loop diuretics block sodium-potassium chloride cotransporter. Blockage of this transporter causes decrease in reabsorption of sodium, water, potassium, and chloride. With decrease in reabsorption of chloride, income of chloride molecules into the blood decrease, which potentially can cause hypocalcemia. Decrease in reabsorption of potassium molecules results in decrease in income of potassium into the blood, which potentially can cause hypokalemia. Hypokalemia is a well-known side effect of diuretics, but the incidence of hypokalemia depends on type of diuretic. We know that thiazide diuretics potentially can cause severe hypokalemia. Loop diuretics also can cause hypokalemia, but typically they cause a milder degree of hypokalemia. The average decline in the serum potassium concentration in patients treated with loop diuretics is 0.3 milliequivalent per liter. The milder decrease in potassium level caused by loop diuretics is most probably related to a much shorter half-life of loop diuretics compared to thiazides. Long-term intake of thiazides and loop diuretics can cause 15% decrease in potassium level, which is quite significant. The most serious potential complication of hypokalemia is the development of arrhythmias. We should be especially careful with diuretics in patients on cardiac glycosides, because they can precipitate digital toxicity. In addition to this, diuretic-induced potassium and magnesium depletion are considered as one of the factors that increase the risk of sudden death, and we know that it's because they increase the risk of arrhythmias. The second problem is that hypokalemia can cause mild increase in blood pressure, and last but not least, statistically, patients with hypokalemia have increased incidence of strokes, which is also not very good. We have to know that hypokalemia affects blood glucose level. Hypokalemia causes decrease in insulin secretion, which in turn causes increase in blood glucose level. And to explain this feature, we have to recall insulin secretion. So here we have pancreatic beta cell. Beta cells have GLUT1 transporter. This transporter provides transportation of glucose into the cell. Also, they have ATP-sensitive potassium channels. And we have to know that in rest state, potassium channels are opened. So, because potassium is intracellular ion, which means that the concentration of potassium inside the cell is much higher than the concentration of potassium outside the cell. While potassium channels are opened, potassium constantly leaves cell. Also, beta cells have voltage-gated calcium channels, and in rest state, calcium channels are closed. So calcium, which is extracellular ion, in rest state, cannot enter into the cell. Also, beta cells have intracellular vesicles, and intracellular vesicles have already formed insulin and C-peptide. When glucose enters into the beta cell, glucose undergoes phosphorylation by glucokinase to glucose 6-phosphate. Glucose 6-phosphate undergo glycolysis with subsequent degradation in Krebs cycle and electron transport chain that results in production of ATP molecules. ATP molecules activate ATP-sensitive potassium channels. With activation, potassium channels close. If potassium channels close, potassium begins to accumulate inside the cell. With increase in positively charged potassium ions, membrane potential increase. For example, from -70, membrane potential increase to -50. And the state when membrane potential becomes more positive, we call depolarization. And depolarization triggers activation of voltage-gated calcium channels. If calcium channels open, calcium by concentration gradient begin to enter into the cell. And increase in intracellular calcium triggers exocytosis of vesicle, with release of insulin and C-peptide into the blood. The fate of C-peptide is rather prosaic. C-peptide incomes to the kidneys, and kidneys excrete C-peptide from the organism into the urine. Insulin in the blood stimulates tissues to consume more glucose. And because glucose begins to income to the tissues, glucose level in the blood decreases. In addition to this, beta cells have GLP-1 receptor, which provides regulation of insulin secretion. Glucagon-like peptide 1 in the blood binds to GLP-1 receptor, With binding, receptor becomes activated. Activation of GLP-1 receptor stimulates closing of potassium channels and opening of calcium channels. As a result, more calcium molecules income to the cell, and with increasing intracellular calcium level, exocytosis of insulin increase. Interesting that the amount of glucagon-like peptide in the blood is controlled by a specific enzyme called dipeptidyl peptidase 4. This enzyme provides inactivation of glucagon-like peptide. In simple words, DPP4 destroys GLP-1 molecules. Usually, when we mention diuretic-induced hyperglycemia, we mean thiazide diuretics. But loop diuretics can also cause hyperglycemia. And the major reason why diuretics can cause increase in blood glucose level is because they cause hypokalemia. Decrease in potassium level causes inhibition of insulin secretion by beta cells, and with decrease in insulin, blood glucose level will increase. And because thiazides are more potent potassium-lowering agents than loop diuretics, thiazides have a higher risk of hyperglycemia. So let's explain how it works. Diuretics cause hypokalemia. With hypokalemia, the amount of potassium ions outside the cell decreases. This causes increase in potassium concentration gradient, so now more potassium ions will leave the cell. As a result, the amount of potassium ions inside the cell decreases. Decrease in potassium intracellular concentration causes decrease in membrane potential, which results in decrease in magnitude of depolarization. And the weaker is the depolarization, the smaller amount of calcium channels become open. This causes decrease in calcium influx into the cell, and the smaller becomes the concentration of calcium ions inside the cell, the less active becomes exocytosis. As a result, the secretion of insulin and C-peptide into the blood decreases. And with decrease in insulin concentration, glucose uptake by the tissues decreases. So more glucose molecules will remain in the blood. As a result, blood glucose level increases. So it's the mechanism how diuretics through hypokalemia cause hyperglycemia. With decrease in blood potassium concentration, the activity of sodium-potassium pump decreases, and with decrease in sodium-potassium pump activity, the income of sodium into the blood decreases, so hyponatremia develops. And because water moves together with sodium, with decrease in income of sodium, the income of water into the blood decreases. So loop diuretics cause decrease in total volume of fluid in the general circulation, which can really help in case of congestive heart failure, for example. Exactly because of this effect, we prescribe loop diuretics. With decrease in reabsorption of potassium, the concentration of potassium inside the cell decreases, and the lower is the intracellular potassium concentration, the lower becomes the flux of potassium into the lumen of ascending limb. This causes decrease in lumen positive potential, and without lumen positive potential, we cannot reabsorb calcium and magnesium molecules. Decrease in calcium reabsorption will cause hypocalcemia, and decrease in reabsorption of magnesium will cause hypomagnesemia. So, as a result of loop diuretic effect, we cannot reabsorb 5 water and sodium molecules. So now there are 5 extra sodium and water molecules that income to the distal regions. And in the distal region, we have sodium-hydrogen exchanger. The activity of this exchanger is regulated by sodium concentration in the lumen. And because now these extra 5 sodium molecules create a very high concentration of sodium in the lumen, increase in sodium concentration causes increase in activity of sodium-hydrogen exchanger. As a result, we can reabsorb 2 extra sodium and water molecules. But in exchange, we have to transport 2 extra hydrogen molecules from the blood into the lumen. First of all, these 2 extra hydrogen molecules in the lumen will make urine more acidic. But the most important feature is that When we take away hydrogen molecules from the blood, hydrogen concentration in the blood decreases, and with time, loop diuretics can cause metabolic alkalosis. And as we know, any changes in pH balance can have dramatic consequences. In the end, we have 2 extra water molecules that we will excrete into the urine. This significant increase in water excretion is exactly the reason why we call them diuretics. So, in which conditions we can use loop diuretics? First of all, because loop diuretics have the most powerful diuretic effect, we use them in conditions where we have to rapidly decrease the total volume of fluid in the general circulation. So we use them for practically any type of edema. Also, because loop diuretics cause decrease in calcium reabsorption, we can use them for acute hypercalcemia. In addition to this, we can use loop diuretics in case of hyperkalemia, because loop diuretics cause decrease in potassium reabsorption. We use loop diuretics in case of acute renal failure, and there are 2 reasons. First of all, they increase the activity of COX enzyme, which results in increase in production of prostaglandins. And prostaglandins cause vasodilation of renal afferent arteriole, which will cause increase in urine flow. And also, because in acute renal failure, potassium level becomes extremely high, loop diuretics can help us to eliminate extra potassium molecules. Also, we can use loop diuretics in case of anion overdose, which is really helpful in treatment of intoxications by bromide, fluoride, or iodine. Loop diuretics inhibit the reabsorption of anions directly, and in addition to this, loop diuretics increase the rate of urine flow, which decreases the time for absorption, so it's sort of indirect effect. The most specific side effect of loop diuretics is ototoxicity. We believe that loop diuretics cause edema in the epithelium of stria vascularis, which results in ototoxic effect. Stria vascularis is a part of the cochlea, and cochlea is a part of the inner ear involved in hearing. So, if something will happen to stria, it will immediately affect hearing sensation. The reason why edema develops is that loop diuretics cause inhibition of crucial enzymes and transporters. First of all, loop diuretics inhibit sodium-potassium ATPase and adenylate cyclase. In addition to this, loop diuretics inhibit magnesium ATPase and succinate dehydrogenase enzyme. On this picture, we can see the expression of sodium-potassium ATPase before and after injection of Ethacrynic Acid. There is a clear difference. After the injection of loop diuretics, the expression of sodium-potassium ATPase significantly decreases. In addition to this, we know that loop diuretics inhibit sodium-potassium chloride cotransporter in the kidneys. But this transporter also plays a crucial role in the stria vascularis. And if sodium-potassium chloride cotransporter will not function properly, it will affect the state of stria, and thereby it will affect hearing. But loop diuretics also have indirect ototoxic effect. We know that some drugs have ototoxicity, for example gentamicin or cisplatin, but on their own, they have only mild ototoxic effect, because they cannot penetrate through the blood-cochlea barrier. So you won't typically expect hearing loss after a single treatment by gentamicin. But if you will prescribe them together with loop diuretics, this can become really dangerous. The reason is the ability of loop diuretics to damage the tight junctions in the blood vessels of stria vascularis, which will increase the permeability of blood-cochlea barrier. So, loop diuretics make blood-cochlea barrier more permeable, and in this state, such ototoxic stuff like gentamicin can leak through the barrier in high concentrations. As we know, loop diuretics indirectly inhibit reabsorption of magnesium, so hypomagnesemia can be expected. In addition to this, loop diuretics increase the excretion of hydrogen molecules, which can cause hypokalemic metabolic alkalosis. And also, loop diuretics can cause hyperuricemia. The mechanism is that loop diuretics cause significant decrease in total volume of fluid in the general circulation, and in hypovolemic state, the reabsorption of uric acid increase. As a result, uric acid level in the blood will increase. And the last potential side effect is allergic reactions to loop diuretics. The reason is that all loop diuretics except Ethacrynic acid are sulfonamides, and sulfonamides are extremely allergic substances. So, with loop diuretics, there is increased risk of allergic reactions and interstitial nephritis, and the safest loop diuretic in terms of allergy is Ethacrynic acid.